homelessness. Thanks. Today we'll be discussing partnership opportunities at the intersection of healthcare and homelessness, with a specific emphasis on centering equity and peer models in cross-sector partnerships for street medicine. So to kick us off, I will have all of the panelists and speakers will introduce ourselves, and then we'll go ahead and get started. My name is Katricia. I am a policy analyst with Homebase, and we are the ones hosting the webinar. Jillian, would you like to go next?
Sure, thanks, Patricia. Hi, everybody. Happy to have you here. I'm Jillian Marchetti. I'm also with Homebase. And one of the areas that I focus on is homelessness and healthcare coordination. So really happy to be here to talk about street medicine today.
Erica? Or yeah.
Yeah, hi everyone. I'm Erica Xiao, a research associate at Homebase, and I'm excited to share some racial equity and peer model best practices with you all.
Good afternoon, everyone. I'm Rosie Vasquez. I'm the founder and executive director of Community Through Hope, and I'm very excited to be sharing our street model with you today.
Amazing. Thank you all. And then I think we'll go ahead and get started. So to kick us off, we'll do just a little bit of an introduction. You can go ahead and go to the next slide. It'd be great if in the chat you can put your name and organization or something you're grateful for. And while we do that, I put a link in the chat to a Jamboard. And if everyone clicks that open, you can add, it's this cool thing where you can add little, Jillian, are you going to switch screens over to the, oh, sorry about that. Few screen swappings. But if you click that Jamboard link, I see some of you coming in there. You can grab a little sticky note on the side and type in your response to the question, which is, what existing practices do you implement already for street medicine? So you can copy that sticky note that's there or click the sticky note one on the side. Are we on the right slide for the Jamboard? I may have sent in the wrong one. Well, if you go to the top of the Jamboard, there's an arrow, and I guess we're trying to go to the first screen, and we'll do the what are you hoping to learn as well. And it's totally okay if you are not currently implementing anything related to street medicine, and maybe no one is. In that case, feel free to go to the second slide, which is what are you hoping to learn from this webinar? And start adding some things there that you're hoping to learn today.
And sorry to jump in, Katricia, but just if anyone hasn't used Jamboard and aren't comfortable and have questions about how to use it, please don't be shy. If you want to test it out and try it out, definitely let us know and we can help you. Or you can just throw things in the chat.
There we go. Awesome. Great. Well, feel free to keep adding to this as we go, and we'll refer to it to make sure that we answer any questions that come up and make sure we touch on some points that you all are hoping to learn about today. And just keep this Jamboard up if you have it up right now, because there are a few other slides that we'll go to later on in the presentation. So I think to get us started, and then as well, if you want to keep dropping your name and where you're from in the chat, I just want to cover first what we're going to go over today. So we're going to talk about how street medicine can help strengthen the COC continuum of care and health system partnerships, and how to intentionally incorporate people with lived experience into street medicine programs to ensure equity. So with that, we'll be discussing what we mean by equity and what peer models are in relation to street medicine. We'll talk a bit about how this can apply to vaccine distribution and vaccine ambassadors. And then we'll also have a highlight from the community, which is Rosie, who's on our panel today.
All right, thanks, Katricia. So I'm going to walk us through, some of you are here to learn a little bit more about what street medicine even is, which is great because we're going to go over that a bit first before we get into the rest of it. So the most basic way to think about street medicine is it's really, the fundamentals of it are, it's really a way to engage people who are experiencing homelessness, particularly people who are unsheltered, to provide direct access to healthcare where they are, right? So if they're living in an encampment, if they're somewhere else living outside on the streets, if they're in their cars, it's a way to deliver medicine to them where they are, how they need it. So that's the sort of basic overview, and then we'll go through some of the details of how to kind of conceptualize what a street medicine program might look like, and also go through some examples too to help flesh it out. So again, this is sort of, this isn't every street medicine program will look different. Sometimes they go by slightly different names. They can be kind of thought of as medical outreach or mobile clinical care, portable clinical care. We'll later on in the slides, you'll see the phrase backpack medicine. So there's different ways to think about it. But we've got some of the sort of core components here on this slide to give you a general sense. So they're essentially, ideally, I should say, multidisciplinary teams. So they could include, or they can and should ideally include both healthcare providers and also, social service providers, folks who are outreach workers, who aren't necessarily, clinical care providers. So the more sort of multidisciplinary, the better, to make sure that you're providing care and also building relationships with folks and identifying people who need care, and also being able to connect folks to other resources is the goal, really. But again, the idea is to bring healthcare and services directly to people who are living either on the streets or in encampments or otherwise in unsheltered environments. It can be, depending on the team's makeup, it can be essentially the same kinds of care, the same kinds of primary care that are done in clinical settings. But the idea, again, is to bring the medicine and the treatment and services directly to folks where they are. And ideally, we're working to prevent medical conditions that are existing, that people are facing, that are living outside, prevent those from deteriorating to the point where folks actually need emergency care as a result of conditions that are treatable or preventable. So there are, I think in some ways, especially if you're working in a healthcare setting and you're interacting with folks experiencing homelessness as part of your job already, or if you're otherwise connected to folks who are unsheltered, you might have some idea of why the ability to provide health care directly to folks where they are is so important. But just as, for some level setting and for folks who are not as experienced with that, some of the reasons that folks who are living unsheltered may not be accessing more traditional medical settings. There's lots of reasons. This is not a comprehensive list, obviously, but first of all, I think even for folks who are not unsheltered, it's really challenging, can be really challenging, right, to access medical care settings and navigate health systems, especially if you have particular conditions. If you're stepping away from, you're traveling away from where you stay, there's also a risk of, your property being stolen or destruction of something, or just there's an unease, right, with leaving behind your belongings, which is not easy to take with you if you're going to travel to a healthcare setting. Part of the challenge is accessing medical sites is also obviously transportation, simply getting there, keeping track of appointments, all kinds of things. We really need to recognize the effects of traumatic experiences and trauma. Lots of folks have had negative experiences in accessing the mainstream healthcare system and going to clinical sites, especially for folks who are Black, Indigenous, other people of color. Not every individual person, obviously, but a lot of folks within those categories and other groups, and the communities as a whole, there's a lot of history of negative interactions with medical systems. And so there are some really understandable hesitancies to go directly to medical care sites, especially hospitals. And then also folks who are, living on the streets are needing to take care of a lot of really basic needs. And so sometimes, even for those of us who have roofs over our heads and are not thinking about where our next meals are coming from, all those sort of basic needs are met. Even then, it's really difficult to focus on things like preventative care or keeping on top of your healthcare. And so if you add on to that just a need to take care of your absolutely basic fundamental needs on a daily basis, often figuring out the medical system is not necessarily something that you can prioritize day to day. So again, lots of needs, lots of reasons that being able to deliver medical care, quality medical care directly to folks where they're at is really important. So this obviously ties into sort of the why we need street medicine. Not only are the aforementioned things, the reasons that folks are not necessarily going to be interacting with the healthcare system in the traditional sense if they're living outside, but we also see amongst people experiencing homelessness, and especially unsheltered homelessness, really highly disproportionate rates of illness, disability, premature death. So the actual healthcare needs are just really substantial among folks experiencing homelessness. On the flip side, if we're looking at from the healthcare system's perspective, there can be really high utilization costs associated with folks who are experiencing unsheltered homelessness. The costs are much higher than the sort of average national costs associated with interacting with the healthcare system. There is, because folks are not often connected to primary care or for other reasons, there's often for things that are not necessarily emergency situations, there's a lot of access of emergency departments, emergency rooms to access what would be traditionally considered more routine medical care, and increased hospitalization rates as well for folks who are presenting at more advanced stages, again, because of the lack of consistent, quality health care on an ongoing basis. And then on the plus side, the benefits of street medicine, some of those we have on the bottom half of the slide, right? That we're looking at delivering more consistent care to folks where they are, can help lower healthcare costs and unnecessary utilization patterns of hospitals and emergency departments for non-emergency situations, and of course, improve the healthcare of folks who are living on the street, which is critical benefit of this as well, and just the general improvement of access and efficiency to healthcare systems for folks, not just for folks that we're talking about, folks who are unsheltered, but also for everyone else who's using the healthcare system. The more efficiently we can utilize all these resources, the better for everyone. So thinking about two particularly proven strategies that can really help improve the healthcare of folks experiencing homelessness, both access to care and continuity of care, both of which can be facilitated through effective street medicine programs, right? So for folks that don't have access to healthcare on a regular basis, they're at increased risk for later stage diagnoses of diseases if they're ever able to get diagnosed. It's more difficult to manage conditions, right? Either through medication or otherwise. And again, we'll repeat a couple of points a lot of times because they're really critical, but hospitalization for conditions that would be preventable if there were consistent access to healthcare. And then of course, without continuity of care, which is another goal ultimately of street medicine, is not just to be able to provide care to folks on the street, but also hopefully help connect them to more ongoing healthcare providers and support to help manage conditions and continue to take care of health on an ongoing basis. The trust that's necessary to make that happen is sort of impossible to get, right? If you're inconsistently sort of dropping by and maybe providing some healthcare to folks sort of on an ad hoc basis, or sometimes people come into an emergency room and get lucky and get connected to someone that can kind of help them over time. The more inconsistent healthcare delivery is, the less likely someone is going to be able to trust in their ability to kind of work with medical professionals to have, feel empowered to control their health over time. And having a really consistent street medicine program that helps build relationships and foster connections can really go a long way towards ensuring that continuity. We also just want to point out, and we'll, as Katricia mentioned, earlier when she was introducing what we're going to cover, we will be talking about equity specifically, but really just want to point out that addressing the healthcare needs of folks who are unsheltered is a really critical part of achieving health equity. Folks who are experiencing homelessness are really disconnected from healthcare in a lot of different ways. And so in order to actually achieve any sort of health equity, this is a really critical population to figure out how to work with well and deliver the services and connections they need. So I'll pause for questions in a minute for if anyone has questions about street medicine in general, but I also just want to mention that we're hoping that from this webinar, we're not just convincing folks or elaborating on the idea of street medicine as a good intervention, but really want to focus on how critical it is to when doing street medicine, really partner across the healthcare system and the homeless response system. And so I just wanted to, these are just like very high level benefits of doing that, as opposed to kind of operating just within the healthcare system and not partnering on the homeless response side. So some of these might feel a little bit obvious, but I just feel like we need to cover them too, that, you know, the folks who are working on the homeless response system side have many times existing relationships, have connections with folks that are in unsheltered communities and individuals who are living unsheltered. So they can really help. That's, you know, part of the multidisciplinary team approach is having folks who are kind of on both sides, so that you're leveraging the relationships that already exist in order to kind of meet people, identify folks who need healthcare delivered to them where they are, and also to, you know, foster the trust that's really important for any kind of, you know, healthcare provider patient relationship. There's also the ability to connect folks to housing and other resources that are really critical to maintaining health, right? So it's pretty, I hope everyone on this call is already, doesn't need to be convinced that housing is a really key social determinant of health. And so for folks who are living unsheltered, there is really only so much healthcare delivery that you can provide on the street before certain things might plateau, right? Like folks really, in order to maintain health, housing is really critical. So those connections to housing resources and others that can help stabilize folks in housing is obviously really critical to managing healthcare over time as well. And then also, this is one thing that hopefully Rosie can speak to a little bit and we can talk about in our examples, but street medicine programs can be a really kind of low barrier entry point into partnering across, you know, between the healthcare system and the homeless response system. Some of you may have been parts of lots of webinars that talk about how important it is to partner across systems, and coordination is so important and integration is ideal, but it's really hard to start that sometimes. And street medicine can be a somewhat simple, low barrier way to kind of suss out what that partnership might look like, or sort of start to build relationships across systems. So that's one of the reasons we really wanted to highlight it today as a kind of as one approach to sort of get that longer term and hopefully more expanded partnership started. So we're going to send these slides to you after, so I won't go through too many details of these, but we have a few examples, and of course Rosie's going to speak later, but these are just a few examples of some street medicine programs that currently exist that we wanted to touch on, just so that, at least for anyone who's less familiar with street medicine, it doesn't feel like just a theoretical idea. So Alameda County, right here in California, has their healthcare for the homeless program has street health teams that do regularly scheduled outreach and services to unsheltered folks that are living in encampments and in vehicles and RVs. The thing I want to highlight about their program is that they have psychiatric and substance use treatment services embedded within their teams, which is really fantastic and sometimes a bit unique among street health programs. So I wanted to call that out specifically, but they have multidisciplinary teams that not only include psychiatrists and substance use nurses, but also outreach workers. So they have that connection to the homeless response system as well. Santa Barbara, so we have one more California example. So Santa Barbara has a program called Doctors Without Walls, which is a volunteer-run nonprofit that provides medical care to unsheltered folks in Santa Barbara. They refer to themselves as backpack-based medicine. So they have also a clinician-led team that includes a doctor, med students, and what they call a peacekeeper, which isn't necessarily a police officer, for example, but that could be someone that's has good connections with folks who are living unsheltered. So someone to kind of like be a little bit of a liaison. And then they also have what they call a companion care program, which is interesting. It matches trained student volunteers with folks to kind of work together to help sort of navigate the process of connecting to more primary ongoing care. And then we have a couple of non-California examples just wanted to share as well. And we'll send resources after the fact, links to places where you can find additional examples of programs. But the Portland Street Medicine Program is a coalition of volunteer medical providers, so similar to Santa Barbara, but as well as social workers, care managers, and then folks who are just wanting to work with the team to help reach folks living on the street. So they describe their model as, you know, announce and be identifiable. So make sure, so that's, you know, part of the sort of building trust and making sure folks are aware of who you are. If you're, you know, entering an encampment, for example, you're entering a community. And so it's really important to make sure that folks are aware and that you're invited to come into where people are living. And so that's a big part of their model. And like a lot of medicine programs, street medicine programs, they carry backpacks that have supplies, which could include medicine as well as other supplies to provide basic acute care, as well as help supporting managing folks' chronic conditions. And then they also help to triage. So for anyone who needs connections to emergency or urgent care, they can make those connections. And for more complex conditions, they work to help connect folks to specialty care as well. And then the final example I wanted to highlight is a bit of a kind of gold standard. So Pittsburgh Mercy's Operation Safety Net in Pennsylvania is really the foundational street medicine program. So Dr. Jim Withers partnered with formerly homeless folks back in the early 90s to kind of make what he called house calls to folks who were living unsheltered, and did that nightly, sort of doing rounds basically. And so that's been built up over time, and they're still a really active organization. They're one of the, they helped found the Street Medicine Institute, which we'll again send around with resources. But so they've got a really robust program that over the years has built up lots of connections. And so we wanted to make sure to highlight this. So their team consists of outreach specialists, clinical volunteers, medical students, and then also other non-clinical support to help make those connections to social services. They offer basic medical care as well as other necessities. And they also have medications with them, including over-the-counter and also antibiotics and prescription medicines for folks with chronic conditions. And then really, really key, especially to what we wanted to talk about today, is their connections, their ability to make referrals to other healthcare, ongoing healthcare, as well as human services. And they make referrals directly through the homeless response system's coordinated entry system, which is basically the main connection point to get folks connected to housing and other related services. And I just wanted to mention, because I have this information available, that you kind of get a sense of the scope of their operation, that in 2020 alone, they provided services to over 3,500 people and transitioned over 600 people into housing, which is really tremendous, especially so they obviously have the really strong connection to the housing side. And then there's some information about over the past almost decade, how many folks they've actually helped connect to permanent and transitional housing programs. So really encourage you, if you're interested in this, to kind of take a look at some of these examples, and they're a good one. They're a good one to start with for sure. So with that, I'm going to hand it over to, or actually before I hand it over to you, Erica, do folks have questions? I can look in the chat if people have questions, particularly about just street medicine as a program or anything that I've gone over so far. Oh, I think this was answered in the chat, but just quickly, Homebase does not deliver street medicine. No, we're a technical assistance provider. So we provide support to communities on all kinds of things relating to homelessness. And so we do a lot of work with communities on all kinds of things relating to working with folks who are living unsheltered and otherwise homeless. But part of that is really focusing on building these partnerships with healthcare community. So any other questions, or I can hand it over to Erica to talk about equity. Great, go ahead, Erica. Thanks.
Cool. Thanks, Jillian. Oh, did someone raise their hand? Kelsey, did you want to ask a question?
Yeah, so I'm curious about two things. I don't work in a healthcare setting. I work at a social service agency, but we serve lots of folks who are homeless. And I'm curious about how service providers who are not in healthcare systems can reach out to these street medicine teams and make referrals. So I'm thinking of women who I know are living outside, who I know have health complications, who are consistently not making it to urgent care or the hospital, but who need care, and how these kinds of teams receive referrals.
Yeah, that's a good question, Kelsey. I think that varies a lot. And I will say I guess I don't have a list in front of me that can prove this, but I do think that in California, and I suspect a lot of places, many street medicine programs come from the healthcare system. And so they're not necessarily as connected to the homeless response system or providers. But I think it really depends a lot on the capacity of the team and how they're set up. Like some teams will have regularly scheduled sort of rounds. Really to go to certain encampments or certain places, or they'll have kind of pop-up clinics at different places. And so the way that teams are set up really varies. But there's nothing to stop. I think it would be great as long as your street medicine program is communicating with the homeless response system. You could certainly set up some sort of either just like referral system where, for example, if your example, someone that's working with a provider, or just if an outreach worker, when they're doing their normal outreach, interacts with someone that needs healthcare, having even just like a phone number or some other, sort of like standing connectivity to alert the street medicine team. I think some, again, depending on capacity, will be able to kind of be more responsive or kind of do what would be more like what you can think of as house calls, actually interacting, like, like responding to a request, as opposed to just the sort of outreach model, which is kind of canvassing areas or having things set up. So I hope that answers, I mean, it really depends. I mean, you can set it up in any way, but I think just coming up with some sort of either phone call based system, if you could do that, or if there's a place you could sort of, have maintain some sort of database or spreadsheet where you're saying this person has this, without private information, this person has this need and they're generally located here, so that someone on the street medicine team can follow up on that.
Thank you. I'm also wondering about how, like if this is mostly, I guess if it's mostly an outreach model, it's probably people are being served once. I know that, there's some efforts here in Sacramento for people to be doing street medicine, but I think people really struggle to find people a second time, or to have these kinds of follow-ups, because people move around a lot. And so I wonder if you have best practices to share about that, or if it's just sort of when you can catch people, you can serve them.
I think when you're this answer will not possibly be able to be comprehensive, but I'll try to answer it briefly. I think if you're starting out, I think it will take a while to get to the point of this, but so it does, I think, look more like an outreach model where you're coming upon people, and they might have healthcare needs that you can serve in the moment, and there's less of the sort of continuity at first. But the idea really is, especially if your team can be somewhat consistent, and to the extent they are doing outreach in similar areas, especially when folks are in encampments and they're not moving around maybe as much, if you can be, I think, being consistent in when you're doing your outreach and being able to communicate, like every Tuesday we're going to be at this location, so folks are aware and they can actually count on it, is really critical to building trust. And then I think, as with any outreach, the more you get to know individual people, the more you can sort of communicate with them in advance. I'll be back at this time, we'll be back at this time. And so sort of like setting up more of a rapport and a consistency, as well as in addition to outreach, incorporating other locations where you're going to be that people can get to. But the idea is that over time you're building the relationships with individuals, just like outreach teams generally do. I think it's just a matter of time and making sure that you're setting up your street medicine program so that you can be as consistent as possible in your timing and your location, so people really know they can count on you. And that will sort of eventually build to that sort of relationship where you're more likely to know where people are and can do the follow-up care, and also connect them ideally to like a medical home of some kind.
Thank you.
Sure. Yeah, sure. Thanks for the questions.
Awesome, thanks. Cool, so now we're going to focus more on racial equity and peer models in street medicine, and then we'll address kind of vaccine distribution applications to that afterwards. Okay, I think for those of you who came to the last webinar, this might be a little bit repetitive, so bear with me a little bit and we'll just we'll dive in. Cool. So just a refresher on the sort of layers of racism that we experience on a daily basis, and that clients are coming into street medicine programs or other sort of healthcare or provider programs with this context. So there's 4 different overlapping layers here that are interconnected with each other on this slide. So we have structural racism, which is the history and current compounded reality of racial bias across institutions and society, institutional racism, policies, practices, and procedures that produce inequitable outcomes based on race. And then we have interpersonal and internalized racism, which is more on a interactive basis between people and driven by beliefs that individuals have within themselves. And the layers that we're trying to address in the work that we do is mainly the institutional level, but of course, keeping in mind that all of these kind of play into each other and compound. Next slide, please. So for those of you who are coming from a more of a healthcare perspective, just to highlight to keep in mind specifically when serving patients experiencing homelessness, there's some pretty stunning data about the disproportionality of individuals experiencing homelessness for most minority groups. So you can see here that the proportion of Black people, for example, experiencing homelessness is significantly larger than their percentage of the overall population. So a lot of the structural institutional levels of racism from the previous slide have compounded to create discriminatory housing practices and a variety of injustices that have led to communities of color disproportionately experiencing homelessness across the US. Next slide. So kind of similarly showing the rate at which most minority groups experience homelessness is far greater than that of whites and Asians. So this is measured as the number of people experiencing homelessness on a given night per 10,000 in the population. Next slide, please. So there's also there's historical distrust in the medical system from communities of color due to histories of unnecessary and non-consensual medical experimentation. So while we're combating vaccine hesitancy and other sorts of hesitancy from individuals who are maybe skeptical of certain types of care, health and homeless providers should be empathetic and understand the context around which some of this distrust comes from. So specifically around Black, Indigenous, and people of color clients and patients. This is just a background that is rooted in a reality from many people's families and communities. So for more information on this, we really recommend this Work Safe webinar that we'll link in the chat on Black-centered equity and community engagement. So the minutes that we listed there are specifically powerful, but if you have time, definitely watch the whole webinar as well. Thanks. So when it comes to having a equitable response in street medicine, it's really important to take the specific needs of clients into consideration when planning for their comprehensive care plans, and also acknowledging that racialized trauma is a part of the picture for a lot of these folks. We'll talk about having peer specialist programs to kind of build trust among people who have historically distrusted the medical system. And then on the other side of that, just for organizations to keep in mind themselves, having DEIB practices in your organization makes a big impact on the clients that you serve as well. So having staff that's representative of patients' backgrounds, as well as training staff in working with a variety of backgrounds and having cultural competency skills is really important in making clients feel safe and feel that they can actually come to the organization for for obtaining what they need. Cool. Any questions on that?
Okay. Thanks, Erica. So I'm going to talk about what peer models are and why they're important and how they can apply to street medicine, and then tie in some of this equity piece and how to have equitable peer models. Peer models can apply to anything that you're doing related to any population, but in this case, we're talking about people experiencing homelessness and how peer models can apply to street medicine programs. But I think the important thing to keep in mind here is that peer specialists and peer models can be brought into any system in any organization. So even if you're not specifically doing a street medicine program, peer models are still a great thing to consider for whatever program you are running. Thanks. So what are peer models? Peer models are frameworks for providing services and support that center around peer support. So peers are those who share similar experiences or backgrounds. And a peer supporter is someone who has knowledge from their own experiences, like in this case, someone who has experienced homelessness or who has experienced certain health problems or health needs. A peer specialist is a person with lived experience of a specific need or healthcare need. So in this case, you might want someone specifically who has experience with homelessness and recovery from substance abuse or some kind of illness that is common among other people experiencing homelessness as well. And has been, a peer specialist is also someone who has been trained and certified to help their peers gain hope and achieve specific life and healthcare goals. The 4 components of peer support are up in the top right-hand corner. They include assistance in daily management of healthcare, social and emotional support of their peers as they stay motivated to reach their goals, linking people to clinical and care settings and community resources, and providing ongoing support over an extended period of time, ideally. Next slide, please. So why peer models? Providers of healthcare face, and providers in general, can face 2 major challenges when engaging with people experiencing homelessness. First, finding and engaging these individuals in a way that builds trust, respect, and mutual understanding. And second, keeping those experiencing homelessness or formerly homeless engaged in healthcare. So unlike many healthcare workers, peer supporters share similar knowledge and experiences of those that they are providing support to, which places them in a really unique position for providing practical, social, and emotional support and building trust with others through the process. Peer support is very specifically non-hierarchical, it's reciprocal, and it's flexible. It can complement and enhance other healthcare services, and it supports the trust building and engagement process specifically for people experiencing homelessness with healthcare settings. So lived experience of homelessness is really essential to engaging people experiencing homelessness in healthcare and other homelessness services too, mostly because it can help to really quickly build trust. And then how peer models support safe and equitable street medicine is primarily through outreach and trust and familiarity and support. So through outreach, we mean like connecting individuals experiencing homelessness with street medicine teams, someone who has experienced homelessness, who maybe has familiarity with certain encampments or certain communities or where people are on the streets, can really be a huge benefit to the street medicine team in helping get them connected with people experiencing homelessness. But then once you actually make that connection, someone with lived experiences of homelessness can more readily build rapport and trust with other people who are experiencing homelessness. And then this can lead to the peer supporter helping the street medicine team then provide healthcare to people who are in need. Once this trust is built, it can kind of become an upward spiral that helps to encourage people to maintain their healthcare and stay connected to healthcare, and helps the street medicine teams gain rapport with the communities they're working in. And then finally, the familiarity and support piece is really important, because people who lived experience, who are peer supporters, can be an empathic support person who understands what somebody else is going through and can help them feel heard and understood. Next slide. These are just some of the contributions and benefits of peer support. There are many of them, some of which we've already covered, but I think what's most important here is that peer support workers and peer specialists in this particular setting can really help build the bridge between the people experiencing homelessness and healthcare settings. And as we've seen, that bridge can be really hard to build for either one of those groups on their own, and peer support workers can be a really huge benefit to that. Next slide. I just want to touch on quickly what equity in peer models looks like. I think the first thing to say is, maybe I'll just skip down to the compensation part, is that peer support workers should not necessarily be asked to volunteer their time. So it's really important to ensure that peer specialists are incorporated fairly into whatever model is used for healthcare, whether it's street medicine or other healthcare settings, and that they are compensated for their expertise, time, and labor. But going back up to the top, related to that, it's important to provide trainings for people to become peer specialists or peer support workers, and to train them on equity and what equity means. It's important to ensure that peer specialists and peer support workers are representative of the populations that they are supporting. So yeah, I think that's, I guess, self-explanatory, but you obviously in this case want other people who have experienced homelessness. And then at the bottom, ensuring that people who would like to be peer specialists and do not have the required training, that they are given opportunities to acquire that training or education or certification that would allow them to be peer specialists, especially in healthcare settings where some of those certifications are more stringently required. So like especially with issues of inequity and homelessness, barring certain groups from participating in peer models due to educational requirements can further perpetuate the inequities. So you both can like empower people through giving them those opportunities, but also counteract inequities through providing the training that would allow people to become peer specialists. And it looks like that was the last slide on peer models, but it looks like we have a question in the chat or a comment in the chat about a team called Green Shirts who help transition people into shelter who have also experienced homelessness themselves. Yes, exactly. Like that's definitely a great example of a peer model. Next slide. So I think we just wanted to do a quick brainstorm on peer models. So if you go back to the Jamboard link that we shared before, the third slide kind of talks about how peer model, or is asking like how you think peer models could be applied to street medicine. And we've talked about that a little bit, but if anyone has any other ideas, or you want to maybe throw in some ideas about how you could apply peer models to the work your own organization is doing, that'd be great. And maybe no one is using peer models or is not sure yet, and feel free to use this time to ask questions as well. And Jillian, I think while folks are filling this out, just for time's sake, do we want to move on to vaccine distribution?
Yeah, absolutely. Just 1 second and I will switch my screen share back.
Thanks.
Hopefully no one's getting dizzy yet. Okay, thanks, Katricia, and thanks, Erica, for your covering the equity piece earlier. So we do want to move on to talking specifically about, it'd be kind of strange to talk about street medicine right now in this context without talking about the realities of the pandemic that we've been experiencing for a long time and still are. And so we really wanted to take the opportunity to talk about vaccine distribution and put in the efforts as something that communities can really leverage, either in either direction, sort of leverage existing street medicine programs in order to facilitate effective vaccine education distribution, or in places that don't have street medicine programs yet, or maybe are looking to expand them, kind of leveraging the sort of energy and resources and effort that's currently behind vaccine education and dissemination to sort of build a foundation for creating a street medicine program. So, oh, I forgot we had a Jamboard. I probably should have just kept it on the Jamboard. So I'm gonna, maybe before I switch my screen share, I'll see if folks can click to the next slide. I'm curious to see from folks, and we can share if people are adding. I can switch my screen if people are adding. But we really are interested to know, to the extent what vaccine efforts are happening in your community, specifically in connecting folks that are living on shelter to COVID vaccine. And that can include both the educational piece and communications about the existence of the vaccines and the benefits of it, and addressing any concerns or questions that folks have, all the way through the actual delivery of the vaccines to folks, especially in unsheltered environments, like through delivery to either through healthcare providers showing up at shelters or in encampments, or through outreach, or having kind of some places are having sort of pop-up events that are specifically geared towards folks that are living unsheltered. So it'd be great to see what you all are aware of in your communities that's happening. And Katricia, if you'll just yell at me if I should switch my screen to share the Jamboard. Otherwise, I'll give folks a few minutes, or you can put it in the chat too.
So yeah, some of what we're seeing in the Jamboard is that what people would like to be doing is having more education on vaccines and ease of access. We're bringing vaccines directly to people on the street. Some vaccination efforts people are already undertaking is having vaccination clinics for unsheltered folks at key locations. I don't know if you need to switch, but you can.
Oh, well. I did. I figured might as well be there. I'll make it so that, and I think we've said that we'll send these around so people can keep putting things, but great to see in
Yeah.
real time too. Great. And for the folks who ever put in news stories about getting vaccinated, are they particularly aimed at folks who are experiencing homelessness, or do you mean more generally? And you can add it to your thing or come off mute or put it in the chat anyway. Thanks, Erica, for sharing the link again. And then we have someone in the chat saying, would like to see mobile vaccine vans similar to blood bank van that goes directly to encampments. Great. Yeah. Great. Well, yeah, feel free to keep putting ideas or things that you know that are happening and or what you would like to be doing. And again, we'll share these out after and people can continue to come back and look at them and add to them. And I will switch us back again to the slides. So, so feel free to keep doing that over the next few minutes, obviously, but just wanted to kind of point out a few kind of key things relating to the leveraging I was talking about kind of in both directions. So really, if we're thinking about getting vaccines, not just the vaccines themselves, but again, information about them, being able to answer folks' questions, everything relating to kind of the communication piece and the messaging all the way up through for folks who do decide to get vaccinated, being able to actually deliver the vaccines is exactly the kind of thing that we can really use street medicine program or street medicine like programs to accomplish. So to really fully reach folks who are experiencing homelessness, especially in the past, I know this varies community by community and things are, we've kind of been through a few different phases of kind of tentatively reopening up and things like that. There's folks have been, encampments have been more steadily existing, as there was a moratorium on encampment clearing, there were fewer kind of disruptions in encampments. And so folks were in the same place for longer than they sometimes are able to be in certain communities, especially in California. So there was a unique opportunity, as with the entire, as with everything to do with the pandemic in terms of, delivering hygiene supplies and information and making sure folks were aware of the risks and what they could do to kind of prevent being exposed to COVID in the first place. Same thing with vaccine information and education and delivery. Really important to actually reach out to folks where they currently are, as opposed to expecting any sort of rather than putting the impetus on folks to engage in a different way with the healthcare system. And again, here, and Erica will talk about this in a second, but models street medicine programs, especially that include folks with lived expertise and experience in this vaccine education and dissemination is really, really critical for all the reasons that have already been talked about on this webinar, as well as some others. And so we also wanted to kind of just point out a few things that the CDC included in their strategies and guidance and information around vaccination programs, both planning and implementation, that really line up well, again, with street medicine programs. And so really kind of point out the connection of how this can be utilized. So things like making sure you're offering vaccinations in like locations where people that are experiencing homelessness or unsheltered are frequently either visiting or where they're living, which is so essentially kind of creating street medicine specifically for vaccines. As far as communication planning, the CDC recommendations included things like making sure you had flyers at encampments, at shelters, on public transportation, announcing things relating to vaccines at healthcare and other service programs, doing messaging that goes across, email, text, social media, TV, radio, all kinds of media, and making sure to advertise well in advance of any vaccination events, and specifically to folks experiencing homelessness, right? So again, all of these things are things that either an existing street medicine program can be really helpful in making happen and implementing, or can be a way to sort of like start to build up something that is starting to look a lot like a street medicine program, right, via this vaccination education. And similarly, the way that the CDC has, really encouraged and provided guidance around strengthening partnerships across the public health departments and healthcare for the homeless clinics and homeless service providers, it really can go a long way towards building the kinds of relationships and disseminating information and also service delivery in a way that can actually really impact folks' awareness of and desire to get vaccinated and ability to actually access them. So again, wanted to just like point out the opportunity and also that vaccine planning and dissemination, all the resources that are currently behind it have for utilizing street medicine programs, and also kind of building them up in a way that you can kind of demonstrate the value of providing healthcare directly to folks where they're living. That is, one of the cornerstones of street medicine. So I'm going to turn it over to Erica to talk specifically about vaccine ambassadors and how they fit into this.
Cool. Yeah, thanks, Jillian. So vaccine ambassadors is an application of peer models to vaccine distribution specifically. And this is a model that's kind of been pushed by various government agencies, including HUD. So it's basically having trusted and trained community members be the ones doing outreach for individuals experiencing homelessness, especially unsheltered homelessness. So this could include well-respected program staff who have trust of those communities already from other outreach work. It should definitely include people with lived experience of homelessness, especially people who came from that community and were potentially initially vaccine hesitant, but then got their vaccine and changed their mind about it, to just kind of see folks who have been in the same boat through the process, as well as kind of back to the equity piece, including members of racial groups that are most impacted by homelessness and COVID-19. So having Black, Latinx, Indigenous folks be part of that program is really important. I'm going to drop a link in the chat that we'll also send out for potential funding options federally for the vaccine ambassador, to run a vaccine ambassador program specifically, and then also a job descriptions possibility. So folks can just kind of take that and reuse it if they're trying to start a program. I think I'll hand it back to Jillian to introduce Rosie.
Thanks, Erica. One other thing I just wanted to point out, and sorry, I'm to jump on your piece, Erica, but something that's come up a lot in work that some of us have been doing over the last year and a half, and especially since the vaccines have become available, that I think really points to the critical need for and benefits of having vaccine ambassadors, who are folks with both lived experience and who are members of racial groups who are both most impacted by homelessness and COVID-19, and again, have a lot of reasons, as Erica already explained, to be sort of mistrustful of the healthcare system. I think one thing that's a little bit on the flip side that we've been hearing through focus groups and from folks who are acting as vaccine ambassadors is that I think, given all of that, there's a tendency of, white folks like me and others who are working in the healthcare system to maybe think, to assume that some individual person who is part of a group that you might think might be overall hesitant might not be willing or even interested in talking about things like vaccination, and that can be just as dangerous and risky as trying to push it. And so I think that's another place where folks with lived experience of various kinds and of overlapping identities can be really helpful in talking directly to folks, because those assumptions that people will not be willing to engage in the conversation, or aren't willing to hear the information, and in a time when vaccinations are really one of the key things we have to fight this pandemic, is, I think, just as dangerous. So just wanted to point that out specifically, because I think it's a thing that I, at least, again, as a white person with good intentions, probably would not have thought about if it hadn't come up specifically. So just wanted to name that. So I am going to turn it over to our community presenter, Rosie Vasquez, who I'm very excited could join us. I think it's really great that Rosie's able to be here. She's the CEO and founder of Community Through Hope in Chula Vista, and she will tell you about that program and herself more effectively than I could. But I just wanted to say, one of the reasons I'm so grateful that Rosie came on to speak to us all today is because, we provided examples or kind of descriptions overall of street medicine and some examples of already existing programs, but we're really grateful to hear from Rosie, who's kind of on the front end and from the non-healthcare side of beginning the process of starting one up, working with partners. And so I think, Rosie, you have a really unique perspective and a really helpful perspective for the folks on this call who are kind of hopefully learning a little bit more about street medicine. So I think it'll be really fantastic to hear from you about kind of what the process has been like in planning and thinking through the implementation. So very happy to have you here. Thank you so much for joining us, and I will turn it over to you.
Great. Good afternoon, everyone. I'd like to start off by introducing myself. I'm Rosie Vasquez. I'm the founder and CEO of Community Through Hope. We are a small, mid-sized organization located about 15 miles from the city of San Diego, and are situated right in the middle and are 15 miles south of the San Isidro border into Mexico. So I think it's important to understand our geographical place in this unsheltered ecosystem that is here in the this part of Southern California and in San Diego County. I always try and start off by being very transparent about why I chose to be a provider and address certain issues in my community. I was born and raised in the city that I serve in, 55 years here, and about 12 years ago really hit a very difficult place in my life with regards to peer experience and lived experience. I found myself really trying to navigate through a very difficult um, system where I needed to access mental health care, medical care. I needed legal advice. I needed a lot of help to navigate through my personal crisis. And when I came out of that, what really resonated with me was how fortunate I was that I was able to get through this system. But also, it was very obvious to me the gaps in service, and that I was very fortunate to have a great support system, and what would have happened if I didn't. So after that experience, it was very clear to me that I wanted to address certain issues within my community where I was living and trying to get through that crisis and kind of mitigate a lot of the trauma. Can we go to the next slide? Thank you, Jillian. So, with that lived experience and, this growing need in our community, Community Through Hope was founded. And one of the first things we did that I think is really important to where we are now with street medicine and what we're trying to achieve was we really needed to kind of zero in on a theory of change and also understand how we wanted to address things through a trauma-informed lens. So we spent time trying to develop a theory of change that started with the first thing you can do is to try and prevent trauma and crisis. If not, we would need to intervene. We wanted to have services where people could heal from their trauma and get educated on how not to go down the path that they just successfully healed from, and then eventually be part of the solution that our clients and even our team, that as we all got through our trauma and survived and healed, how could we put our lived experience back, to help change the community and change the landscape around two main issues. And that is the issue of food insecurity in our community and the unsheltered crisis that had hit the city of Chula Vista and pretty much the entire San Diego County and the United States for that matter. I do want to put this through a COVID lens. I think it's important for folks to understand that I said we were a small and mid-sized agency in the introduction. When prior to COVID, February, early February, before the pandemic really took hold of this world, we were serving about 5,500 individuals with our food insecurity programs, and about 1,000 of those individuals were unsheltered clients, families that were receiving GAP services. And now our agency has gone to mid-size, that we are serving close to 25,000 individuals a month, addressing their food insecurity needs. And though the number of unsheltered on record has gone down, you'll see how street medicine was really a necessity for us to look at services for the unsheltered at the street level through a COVID phase 2 type lens. I do want to share that Mission Nutrition, we served over 350,000 individuals from March to March during COVID. We distributed through our small agency 5.5 million pounds of nutrition. That's how great the need was in this area of San Diego County. And we did that in a way that we look through everything. What is the most equitable way to, and with dignity and respect, serve individuals who are facing food insecurity? And that's to provide the most high quality nutrition that we can which is fruits, vegetables, proteins, and grains, and to be able to serve everyone without a difficult process of being, receiving services. Next slide, please. Thank you. So Mission Hope, you say, we try and share with folks that we're in the kind of a state of reimagining several projects and elements of what we do. And everything that CTH does with regards to the unsheltered crisis starts with the client. We are a client-centered agency. The client is at the center of everything, and we feel that it is our responsibility to address our clients with honesty, offering opportunities, and lifting them up, and doing that every day, and being a consistent resource, program, project for the unsheltered community to be able to receive services with dignity and respect. Next slide, please. So why street medicine? I wanted to share that when COVID really hit the South Bay area and the pandemic, everyone was just in emergency mode. At that time, we would serve close to about 75 individuals every day that were unsheltered, unhoused, families, looking at the word homelessness, I would say, car bound, couch surfing to street bound. We were some of the first individuals to share the news with the unsheltered that their entire, ecosystem was not in place anymore. We would have individuals come up to us and ask, what's happening? Where is everybody? I cannot can today. I can't recycle today. I can't panhandle today. There's no bathrooms open. I mean, we really realized that we needed to start planning for what we were going to be able to do when we were in a position to serve without so many COVID restrictions. So the idea of street medicine was, we had bits and pieces of this idea. And one of the main reasons was because of this low income ecosystem. And we just had a service desert here, low income for us means high risk. And many of the services in our area don't see things through a trauma informed lens. They're not, they're looking at these clusters of individuals without stopping to try and work through diversity, having, their version of what they think poverty is, and not understanding that until things are equitable and we truly address trauma that's being put upon individuals that are housing insecure or unsheltered or street bound, that it's going to be very difficult to address these issues. So how do we do that? And we had an opportunity with the Arlene and Michael Rosen Foundation, Home Start, a great group of providers in the San Diego County area, to take a look and try and design a model that would work in our service desert. What was going to be needed. Research was required. For those of you that are on here today, I think that's amazing that you're doing the research and you're trying to understand what a concept of street medicine might look for you in your location, in your area. There was 16 weeks of strategic planning around what street medicine would look like in Chula Vista. And we were very fortunate to have on our team individuals who represented local organizations, Father Joe's in particular, and PATH in San Diego County, who were able to let us glean from their programs what was working, and then try and adapt that to the area where we wanted to do our service. Next slide, please. So Project Refresh is that new innovation of services that we were able to take what was working during phase 1 of COVID, the first year of the pandemic, which was incorporating our GAP services, which was, emergency services, toiletry, nutrition. And we invested in a 2-person mobile shower unit that is located at our site. And our plan, and which we've started, is laying down the foundation for street medicine through Project Refresh. This client-centered, kind of an action-oriented event. We do it once a week. And again, the showers, the trauma-informed services, case management, but we realized we wanted to start trying to affect the health of our clients in a really profound way. So we decided to provide vaccinations at Project Refresh Days, and partnering with the Chula Vista Fire Department and other local services to make that happen, especially Health and Human Services. Jillian, could we show the video? This is going to be a kind of a day in the life of Project Refresh that you're going to be seeing here.
Give me 1 second. Make sure the sound comes through.
Today is strictly for unsheltered individuals and clients that are either street bound, living in their cars, are in transition. We focus services to what we call emergency triage. This is basic necessities: food, clothing, shelter, hygiene. Today we'll be offering mobile showers, haircuts, what we call our clothes closet, hygiene kits. We're very excited that we've added in a layer of medical services. So today, our unsheltered clients will be able to receive COVID-19 vaccination. My goal has always been very client-centered, and that is, if one individual shows up who's unsheltered and is able to receive services, it's been a successful day.
Thank you, Jillian. Really want to shout out the CTH team. I don't know if you, I think it's important when we talk about peer services, peer support, that I, reference our team. Several of our team members now were individuals who lost their jobs because of COVID-19. They were housing insecure. They were in need of nutrition, and they came to receive services at CTH and really found themselves a home and somewhere where they could serve. And this has pretty much been, as far as staffing, volunteering, everything is community centered. 90% of our staff is all volunteerism. And, together we're a community through hope, right? So, being able to use Project Refresh to launch a street medicine program was it was a huge gift. We have a brick and mortar building. We have, I noticed Kelsey mentioned something about, how the question was, how do we keep tabs on clients, and having kind of a centered approach, a hub, somewhere where all these services can come together and provide street medicine, really allowed us to launch this idea, already just having this foundation with a Project Refresh, and then having the building as a hub for street medicine. Next slide, please. So I wanted to share, and I think the green is important. This is the ideal design of Chula Vista Street Medicine. We are currently building on these elements, but we do feel that, our goal and what we're working on is this mobile multidisciplinary team that provides medical and social care directly to unsheltered persons living in Chula Vista. It's not a real detailed mission statement, but I think that's important when you're first starting any project, that you give yourself room to explore what's going to work within your community, what's going to work within your partnership group, and but understanding that that is what street medicine and our dream is for Chula Vista. It's going to incorporate an 8-member team. Currently right now, our model does have a health and human services nurse, but the goal is to have a nurse practitioner, medical students. We've secured a social worker component. We've inserted the peer support specialist at this point. And Community Through Hope is going to be, and we are already setting up the infrastructure for coordination. We've secured a virtual, I think, client record that encompasses the medical work that's going to be done by the street team, as well as case management that will be done by Community Through Hope and our partners. We've selected a day. We're going to do Project Refresh and then use that on Tuesdays to launch the street medicine team. And it will go into the evening, and that's where we'll be providing that medical and social care to the unsheltered. And there was a mention about, I think it was Kelsey as well, like, how do we share that information? What we're going to be able to do through this vertical change portal is to be able to allow our partners to have access to the virtual record, so that we can all be working together from the medical side and the trauma-informed case medical side together, to not only help this client with their using the medical and social care model first, but identifying those who can go through a housing case management model as well. The model we're going to be using is a backpack medicine model. It's an urgent care model where the medical team will go out with backpacks and be able to dispense over-the-counter medication. If we are successful in getting the medical team in place, they'll be able to do prescriptions. And then, of course, the most critical, a lot of studies show that a lot of individuals that are unsheltered that end up in the emergency room are there because of orthopedic issues, diabetic issues. So, this is definitely on our radar and things that we want to be able to address at the street level. We are working, I think, successfully with the Chula Vista Fire Department, which is allowing us access to the emergency rooms and how to coordinate consult services, as well as understanding individuals that are, high utilizers of the emergency room and are, going, we've been able to track one client that's gone almost 20 times, this last month due to their diabetic issues. So if we can, do good work out on the street through this model, hopefully we can alleviate the stress on the medical emergency system. And I think one of the most important pieces of this is, the partnerships and with the local agencies. Fortunately for Community Through Hope and our experience working with the unsheltered, we have a wonderful 42 partner strong agency, and we're really working on those partnerships to engage them and introduce them to our street medicine model. So action through partnerships. I mentioned the Chula Vista Fire Department. And again, the fire department is helping us bridge that gap from, individuals who are on who are unsheltered on the street and how they access emergency services. In our city in particular, the fire department is the ambulance service system, as well as the emergency 911 first responders that take individuals to the emergency room. So this partnership with the fire department is critical because they're actually going to be able to help us identify where clusters of individuals are, who we might want to follow up with. If they didn't launch someone to the emergency room, it'll go into our vertical change system, and the street medicine team will be able to then go and try and locate that individual and provide street medicine to them there. So we're very excited about that partnership. Health and Human Services, though it is a huge machine, CTH does a lot of interacting with our local health and human services, region leadership. And we are, very close to securing this public health resources like nurses to go out and help us with not only, we're providing vaccinations on Tuesdays at Project Refresh, but being able to take that out to the street and do triage there. And having a social worker with us to help with Medi-Cal, getting people registered for their local, Medi-Cal or Medicare services is critical to this, as well as being able to get people to sign up for CalFresh. The FQHC is extremely important. We're in dialogue right now at being able to work with and partner with our local family health centers to have our clients be able to then get an appointment with a primary care doctor and try and develop that relationship with the local clinics. The direct services are critical. We're working with mental health care providers, substance use treatment providers, again, social services, housing providers, with, being very mindful of just our clients, the trauma that they're experiencing, where can we meet them? How can we alleviate additional trauma and suffering? So being able to have direct services to domestic violence, legal, family reunification, and of course, very important, for our LGBTQ plus community to be able to have all these resources on hand when we go out into the street, so that we can do not just this is where you call, but we're calling now and you have an appointment tomorrow, and we're going to be able to transport you to get to that appointment. And finally, community. And community for me includes, our funders. I don't put them in a box where they're not part of the solution. It's not just about securing funding. It's about having our funders feel like they are directly part of the action that's happening at the street level and through our innovative programs. So, engaging community, inviting local, philanthropy groups to participate and be part of the street team and get properly trained and want to be boots on the ground and is super important. With our fundraisers, understanding, our grant needs and how to really work with experts to be able to understand how to properly use that funding so that we can sustain the work that's being done collectively. Programs like these very easily get siloed. Individuals start, this is what we want to do, and we tend to move forward and exclude community, exclude volunteerism. We start, doing a little chasing of money and things like that. And that's, it's something that we are really strategically focused on. Is it's not just about getting funded, it's about including our funders in the action and in the outcomes. And I just wanted to share a little bit about the whole peer perspective of support I think I'll round it out with, I shared a little bit of my story with you earlier. And in all fairness, I had a completely different world before I was put in this journey and kind of given this mission. And had I not experienced what I did and gotten through it and was able to step back and see how important it was that individuals with lived experience could help guide me and let me see that this wasn't the end of my story. Um, I just knew that the experience I had to pay forward. And I think anyone with lived experience, at some point you ask yourself, what can I do with what I've survived or experienced? And that's why not only street medicine, but our nutrition program and everything that we do at Community Through Hope, everyone needs a place where they can go plug in and make a difference. We use this saying at CTH a lot, and it's that broken crayons still color. And we tell this to our clients, we're all broken in a way. So, having this hub where we can provide street medicine to our community, where we can address nutrition, we can look at gap services through a trauma-informed lens with a lot of dignity and respect, I feel is so critical for this next phase of the pandemic, but also just, we'll be experiencing this ripple effect for years to come. And I just encourage everyone to stay outside the box, continue to, stay in action and, just wrap yourself around a lot of great partnerships. And if anyone is interested in learning a little bit more about how we're doing things at CTH, please reach out. There's my email, and I'd be happy to answer any questions.
Thank you so much, Rosie. I think Katricia, I think is gonna moderate a Q&A with our time remaining. So thanks for those of you who put it in the chat.
Great.
Yeah, we've got just a few minutes left. Thank you so much, Rosie, for sharing all of that. And we have seen some questions come up in the chat that Jillian has been answering, but if anyone else has questions for us, for Rosie, please feel free to take yourself off mute or put them in the chat.
Sorry, yeah, I know I distracted a bit in my answering some of them in the chat. I think one question did come from Manuel earlier on that was about how you form the partnerships that you formed, Rosie. You want to speak to that a little bit?
Well, Manuel, I'm a caller. We made a list of resources that were needed for clients, and we just started making phone calls and or going and taking tours of other agencies that we knew were doing good work and that we wanted to partner with. So for me, that's super important, is doing the ask. We weren't shy in asking for support or wanting to partner. I think MOUs and MOAs are very important. They hold both sides accountable, and that seems to really be a draw for partnership, where they understand that this isn't, I need your support. There's an agreement that it's going to be mutual. So you might want to take a look at reaching out and looking through the MOA or an MOU lens to build that relationship.
Thank you. Any other questions? Maybe before we go, if everyone has a moment to just throw in the chat something that you learned today or that you're taking away from today. Yeah, and we'll definitely follow up within the next couple of days with all of the materials as well.
Thanks, Manuel. Good, we did part of our job at least.
You did. Thank you. Thank you. I really appreciate it.
Okay, well, it looks like folks are also starting to hop off. thank you all for co-presenting today, and thank you so much, Rosie, for bringing everything that you did. Community Through Hope is amazing, and we definitely hope to see more of similar programs coming up in the future in different communities.